Think about a complex fracture on a radiograph. When you hold that image up, or pull it up on the PCS screen, there is a very comforting, almost beautiful clarity to it, isn't there?
Oh, absolutely. It's a completely visible, categorizable pathology.
Right. The cortex is breached, the alignment is off, the fragments are clearly displaced. It's a binary reality, broken or not broken. It's essentially a puzzle waiting for a precise mechanical solution.
Yeah, and as clinicians, our entire training is geared towards that exact moment. You know the parameters, the intervention is standardized across the literature, and, well, the outcome is measurable on the very next radiograph.
Exactly. You apply the plates, you insert the screws, you restore the anatomy, and the feedback loop of success or failure is almost instantaneous.
Spot on. It's incredibly satisfying because it's so contained.
But then you step out of the operating theater. You walk onto the ward, or you log into a busy outpatient clinic on a Tuesday morning, and suddenly that radiographic clarity just
It
vanishes.
completely evaporates.
You are no longer looking at fractured bones. You are looking at a landscape of, well, systemic fractures. We are talking about broken workflows, fractured multidisciplinary handovers, redundant administrative processes, and supply chains that are taped together by sheer willpower.
And in that environment, the diagnostic waters become incredibly murky. The breaks are invisible to the naked eye.
But the pain, the friction, and the sheer waste of your time are felt everywhere. Welcome to the Deep Dive. Today, we are taking a massive stack of notes, clinical frameworks and innovation theory, and extracting the ultimate roadmap for medical professionals.
Because that gap between spotting the systemic flaw and actually possessing the map to fix it, that is where so much of healthcare's potential is just lost.
Right. Our mission today is decoding how you take that raw, frustrated insight from the clinic floor and turn it into a viable medical innovation. If you are listening to this on your commute home after a grueling on-call shift, you know exactly what we mean.
You probably have three of these systemic fractures rattling around in your head right now.
Absolutely. Almost every working clinician possesses what we might call a mental list. Sometimes it's a literal notebook tucked into a scrub's pocket or jotted away in the notes app of a smartphone.
More often, it's a mental catalog of grievances, things gathered over years or decades of clinical practice. It is the list of things that are fundamentally wrong with the way modern medicine operates.
Things that nobody seems to be fixing.
Yeah.
It's the handover that is chaotic and consistently loses critical patient data, or the preoperative consent form that requires, triple entry of the exact same demographic details across 3 different software platforms.
Yeah, or the specific workflow that wastes an hour of every junior doctor's day. Or maybe the specific patient population who are quietly slipping through the cracks of your standard care pathways.
And that list, your list, is arguably the most valuable asset in healthcare innovation today. You, the working clinician, are sitting on a reservoir of insight that is, quite frankly, completely inaccessible to anyone outside the hospital walls.
Right, because a brilliant software developer sitting in a tech hub simply cannot see the friction in a busy fracture clinic. They just don't have the context.
Exactly. A venture capitalist looking at spreadsheets cannot feel the systemic risk of a poorly designed surgical tray that arrives missing a crucial component.
But the tragedy is that the vast majority of these clinician notebooks never materialize into anything. They remain entirely theoretical.
They're just grumbled about in the staff room.
Yeah, grumbled about over coffee, maybe occasionally mentioned to a friend who works in technology, and then they simply dissolve back into the daily grind.
Okay, let's unpack this. Why do they dissolve? Because healthcare desperately needs clinician-driven innovation.
They dissolve because the distance between a raw clinical insight and a deployable, scalable solution is vast. And it is not the type of distance most clinicians assume it is.
Right. If you look at the tools and platforms that actually solve the field's most intractable problems, you will almost always find a physician or a surgeon standing very close to the epicenter of the original observation.
But the journey from that raw observation to a rigorously testable idea is fraught with highly specific, predictable failure modes. Clinicians who attempt to walk this path without a structured map tend to fall into a very specific trap.
Building the wrong thing for the right reasons.
Exactly. They build the wrong thing for entirely the right reasons. They pour time, capital, and immense emotional energy into a project that ultimately fails to gain any traction.
So today we are providing that map. We're not discussing how to build a multinational corporation or how to secure a Series A funding round. We're focusing purely on the genesis.
Right. How do you take what you see in the clinic today and transform it into a problem statement that is actually worth building around tomorrow without skipping the foundational steps?
The very first step on that map has to be rigorous validation of the problem itself, right? Before we can even entertain the notion of a solution, we must rigorously prove that the issue at hand is a genuine systemic problem.
And not merely a bad day in the clinic masquerading as one, because from the inside, they feel identical.
Let's pull the listener right into the middle of this because I want to explore the psychology here, what we call the inside illusion. Let us ground this in a scenario.
Okay.
You are 5 hours into a complex pelvic reconstruction. You have templated everything perfectly. The patient is draped, they're under general anesthesia, and the bleeding is controlled but ongoing.
A high-stakes environment.
Very high stakes. You reach out your hand and ask for a specific, specialized offset reamer that you explicitly requested during the team brief. The scrub nurse looks at the tray. It is not there.
Oh, wow. It's a nightmare scenario, but an incredibly common one.
Exactly. The circulating nurse frantically calls the Central Sterile Services Department. The tray was packed incorrectly.
Yeah.
And in that moment, the visceral anger you feel is immense.
Absolutely. Your blood pressure rises, your stress hormones spike.
You are delayed by 30 minutes while the kit is located and flashed, the anesthetist is frustrated, and the entire afternoon list is now in jeopardy. In that specific moment, the cognitive load is so heavy that this missing reamer feels like the single most catastrophic systemic failure in modern medicine.
And that is the crux of the inside illusion. From the inside of that heightened emotional state, a personal, highly localized annoyance and a massive systemic problem feel utterly identical.
Right, your brain is just screaming that the whole system is breaking.
Exactly. The neuroscience of frustration essentially creates a cognitive tunnel. Your amygdala is firing, your focus narrows entirely to the immediate threat, the missing instrument, and your brain desperately seeks a grand narrative to explain the failure.
You convince yourself the entire procurement system is fundamentally broken.
You do. But the difference between a local environmental annoyance and a truly systemic problem matters enormously because, well, emotional frustrations are not the foundation of sustainable companies. Real, reproducible problems are.
So how do we get out of that cognitive tunnel? If I go to the coffee room after that surgical disaster and complain to my fellow orthopedic consultants, they are going to completely validate my anger, aren't they?
Oh, entirely. They will share their own stories about the sterilization department. They will agree it is a crisis.
Right.
And that is precisely why sharing the same context is incredibly dangerous at this stage. If you describe the issue to your immediate colleagues, you are simply shouting into an echo chamber. They suffer from the same local variables that you do.
So what's the test? To determine which one you are dealing with once you scrub out, your observation must pass through 3 distinct pillars of validation, starting with independent verification.
Yes. To test independent verification, you must employ what we call the knowing nod test.
The knowing nod test. I love that.
It's highly effective. You take your observation and you deliberately describe it to clinicians who operate entirely outside your immediate ecosystem.
So not your registrar or your clinical director.
No, you speak to an orthopedic surgeon in a different hospital trust, perhaps in a completely different region. You speak to a specialist in a different country, operating under a different healthcare funding model.
Or even a different specialty.
Exactly. You might describe the fundamental mechanics of the supply chain failure to a clinician in an entirely different surgical specialty, perhaps cardiothoracic or neurosurgery.
And you are actively looking for a specific physical reaction.
Precisely. You are looking for the knowing nod. If you describe the friction and they immediately recognize it, lean in and start sharing their own analogous horror stories regarding that exact same workflow breakdown, then, well, you are likely looking at a systemic reality.
It means the problem exists independently of your specific theater manager or your hospital's specific procurement policies.
Yes. However, if they look puzzled, or if they casually mention that their trust solved this exact issue 5 years ago with a simple barcode tracking system, then your problem is highly localized.
Right. It is a failure of your specific environment, not a universal gap in the market. That is a brilliant diagnostic tool. Which brings us to the second pillar, persistence.
Persistence is fascinating.
If a problem has existed in orthopedics for 10 or 15 years, I think the natural clinical assumption is that it must simply be unfixable. It becomes part of the furniture. We assume that if it could be solved, a massive medical device company would have solved it by now.
What's fascinating here is how we must completely reframe our view of persistence. In the realm of clinical innovation, persistence is not a deterrent. Persistence is highly valuable data.
Data. How so?
If a problem has been actively frustrating intelligent, highly motivated professionals for a decade or more, it tells you one of two things. The first possibility is that no one has ever tried to solve it.
Which, given the sheer volume of capital and talent in healthcare, is exceedingly rare.
Very rare. Which leaves the second, more intimidating possibility. Multiple people have tried to solve it, and they have all failed.
And many clinicians view this as a reason to abandon their idea.
They do, but rather it is a glaring signal that the problem contains hidden complexities. It means the issue is significantly harder than it appears on the surface.
Like an invisible moat.
Exactly. Perhaps the technical software solution is incredibly easy to build, but navigating the data governance and regulatory compliance across different hospital trusts is a nightmare.
Well, the workflow is simple to map on a whiteboard. But the behavioral change required from senior consultants who refuse to use digital interfaces is insurmountable.
Right. Persistence indicates that there is a deep moat around this problem. If you can decipher exactly why others failed, you hold the key to a deeply defensible solution that cannot be easily replicated.
That makes perfect sense. And the third pillar of validation is tangible cost. The consequences of the systemic fracture must be measurable. We are talking about quantifiable patient harm, wasted surgical time, lost departmental funds.
If the cost cannot be articulated in concrete terms, the urgency is an illusion. In healthcare, there are a million things that could theoretically be improved, but hospital trusts and private healthcare providers do not allocate budget to fix things that are merely annoying.
They allocate budget to fix things that are actively hemorrhaging money, causing measurable clinical risk, or violating national regulatory standards.
Precisely.
Hold on, need to push back there. Isn't a daily grinding annoyance that slowly causes clinician burnout a very real, tangible cost? We are seeing unprecedented levels of early retirement and absolute burnout in orthopedics globally.
That is a phenomenal point, and it touches on the profound systemic pressures of modern healthcare. You are entirely correct. Burnout is a catastrophic systemic cost.
Right. If a clunky electronic health record interface is driving brilliant surgeons to quit the profession in their 50s, surely that is a massive problem worth solving.
The loss of a senior orthopedic surgeon due to administrative fatigue costs a system hundreds of thousands of pounds in lost productivity, locum consultant fees, and recruitment costs. However, the threshold required to build a sustainable innovation around that frustration is incredibly high.
Because the finance director doesn't budget for feelings.
Exactly. If you are building a product to solve annoyance, you must do the heavy lifting of translating that psychological annoyance into a metric the economic buyer understands.
You can't just approach a procurement board and say, this software makes surgeons happier.
They simply will not fund it. You must say, this software eliminates 40 minutes of redundant data entry per clinician per day, directly translating to 2 additional outpatient slots per week, which generates a specific amount of revenue and reduces the 18-week waitlist breach penalties by 20%.
Ah, so you connect the emotional drain to the financial drain.
Yes, the tangible cost is absolutely there, but the innovator must bridge the gap between the psychological burden and the operational reality.
That translation from clinical pain to operational cost is where so many brilliant clinicians fall down. And it leads us perfectly into the most dangerous trap on this entire journey.
The immediate solution trap.
Right. Let us assume the clinician validates that the problem is indeed real. It has the knowing nod, it has persistence, and the tangible cost is mapped. Their immediate instinct is to jump straight to the cure.
Because as surgeons, we are fundamentally conditioned to fix things immediately.
Exactly. If we see a massive arterial bleed in theater, we do not stand around the table having a philosophical discussion about the systemic issues that led to the hemorrhage. We clamp it, we ligate it, we solve the immediate crisis.
And that profound bias towards definitive action is exactly what makes a great clinician, but it is precisely what destroys a great innovator.
Here's where it gets really interesting. It is the defining characteristic of the first-time innovator's curse. The clinician conflates the gap in the system with their highly specific idea for a fix.
They begin to pitch their solution as if the solution itself were the profound insight. Let us be absolutely clear on the distinction here. The problem is the gap in the world. It is the unserved patient need, the wasted surgical time, the clinical risk.
And the product is merely one specific, hypothesized way of closing that gap.
Exactly.
And there are always multiple ways to close a gap.
Yeah.
Let us look at a clinical example. If the validated problem is that post-operative wound infections in hip arthroplasty are being detected too late in the community,
A very real problem.
the product could be an AI-powered smartphone application that patients use to photograph their wounds daily. But the product could also be a newly designed, advanced breathable dressing that physically changes color in the presence of specific bacterial loads.
Or the product might not be a physical item or software at all. It could be an entirely redesigned clinical pathway where a specialist community nurse conducts a targeted telemedicine review at day 5 rather than at day 14.
Right, so if you jump straight to the AI smartphone application because you happen to like technology, you become intellectually locked into software development.
You start worrying about data privacy regulations, server costs, and user interface design. You become entirely blind to the fact that a simple operational change or a different physical device might solve the problem more elegantly, more cheaply, and significantly faster.
You have anchored yourself to a specific implementation before you have truly mapped the parameters of the problem.
To combat this premature anchoring, we need a rigid rule. We need the 3X discipline.
The 3X discipline. Break that down for us.
It is a non-negotiable mandate for early-stage innovation. You must force yourself to spend at least 3 times as long describing the problem as you naturally want to.
So when you feel the overwhelming urge to start sketching out the user interface of an app on the back of a napkin,
Stop. Force yourself back to the problem space. Outline exactly who experiences the friction. Detail precisely when they experience it, down to the minute of their clinical workflow. Document their current workarounds meticulously, and analyze exactly why those workarounds are failing them.
I have to stop you there, though. I understand the theory, but you are asking a consultant who is already working 60-hour weeks, managing an endless waiting list and dealing with clinical governance, to sit in a room and dwell in the problem space for weeks.
I know, it sounds like an academic luxury.
It sounds completely impractical in the real world of an overwhelmed healthcare system. Wallowing in the questions feels like a waste of precious time.
I completely understand the friction there. It feels entirely counterintuitive to a high-performing professional who is paid to know the answers. But consider the alternative.
Fill in the wrong thing.
Yes. If you do not spend those extra hours rigorously mapping the exact nuances of why the current workflow fails, you'll inevitably spend 2 years and 50,000 pounds of your own money building a product that fails for the exact same reasons the current system fails.
Right, so it's not a luxury, it's survival.
The 3X discipline is the ultimate risk mitigation strategy. Clarity at the problem level is the only solid foundation from which you can accurately evaluate different potential products later.
So how do we operationalize this? Because a clinician cannot simply sit in a room and ponder abstractly. They need a structured framework to interrogate their observation rapidly and brutally.
They need a mechanism to distill a vague, sprawling frustration into a sharp, testable problem statement. We use a 5-question framework for exactly this purpose.
Let us walk through these 5 questions, and rather than just listing them, let us weave them into a deep, hypothetical orthopedic workflow issue to see how they actually connect.
Excellent. The framework begins by demanding hyper-specific demographics. Who exactly has this problem? And the answer cannot be patients or physicians.
It can't even be orthopedic surgeons, right? That is far too broad a category to build an initial product for.
Exactly. A problem that affects every doctor everywhere is a problem too large for a solo innovator to tackle. The narrower the demographic, the more actionable the problem becomes.
So instead of saying orthopedic surgeons, we refine it. We look at our hypothetical problem and say, this is a problem affecting 15% of orthopedic surgeons who manage high-volume, complex outpatient clinics, specifically those dealing with revision arthroplasty.
Now we have a highly specific target audience. We know exactly whose clinic to visit to observe the problem. We know their specific pressures.
Because you are dealing with the massive comorbidity profile of a revision arthroplasty, the operational friction compounds exponentially.
Right, these patients are older, the consultation times are inherently longer, and the preoperative planning is vastly more complex. The demographic defines the environment.
Okay, so we know exactly who they are. Now, question 2. We need to know how often this happens versus how much damage it does. This is the intersection of frequency and severity.
Frequency and severity are the X and Y axes of your problem space. Let us consider the daily paper cut scenario.
The slow bleed.
Yeah. Perhaps our high-volume revision surgeon spends 12 minutes per patient manually searching through disparate, archaic legacy IT systems to find the original operative note from a primary joint replacement performed a decade ago at a different trust.
It is not immediately life-threatening, but it happens 20 times a day. It destroys the flow of the clinic, causes massive cognitive fatigue, and results in hours of unremunerated overtime.
That is high frequency, moderate severity. Conversely, consider a low frequency, extreme severity problem.
Such as?
Perhaps once every 6 months, a highly specific piece of custom 3D printed implant instrumentation is delayed in transit, arriving unsterilized on the morning of a complex pelvic reconstruction.
Oh, that's disastrous. The case must be canceled while the patient is already in the anesthetic room.
Low frequency, but the severity, the financial cost of the lost theater time, the clinical risk of repeat anesthesia, the emotional toll on the patient is catastrophic.
Both are incredibly valid problems to solve, but they dictate entirely different business models, different regulatory pathways, and different product designs, don't they?
Completely different. The daily workflow issue requires a seamless, highly integrated software solution that is practically invisible to the user. The catastrophic supply chain issue requires a robust, high-reliability logistical intervention with multiple fail-safes. You must define the frequency and severity to understand what type of innovation you are actually attempting to build.
Okay, so we have mapped the demographic and the severity. But question 3 is what keeps nagging at me because of human nature. If this missing historical record issue is so catastrophic to the clinic flow, surgeons are not just sitting on their hands accepting defeat.
No, they're surviving somehow.
Exactly. They're taping the system together to get through the day.
And that tape is what we call the bar of the workaround. You cannot build a sustainable solution without meticulously measuring the tape. I often warn innovators that the current workaround dictates the absolute minimum viable improvement required for adoption.
Because medical professionals are incredibly resourceful. If there is a barrier, they will find a way around it, over it, or through it. Let us look closely at that workaround in our high-volume revision clinic.
Okay, what is the actual reality on the ground?
Perhaps the formal workaround is that the surgeon's secretary spends 3 hours a week telephoning other hospitals, requesting paper records to be scanned and emailed over a secure network, which are then manually uploaded into the current patient record.
Or perhaps the workaround is far less formal and far more alarming. Perhaps the surgeon simply uses a secure messaging app on their personal phone to text a colleague at the other trust, asking them to quickly check the system and send a photograph of the operative note.
Which is borderline non-compliant. It carries clinical risk regarding data governance,
Yes.
but it takes 2 minutes instead of 3 weeks.
Exactly. Now evaluate those workarounds. If the workaround is the secretary handles it and the surgeon never actually sees the friction, then from the surgeon's perspective, the urgency to learn and adopt a new complex software system is incredibly low.
Right. They will simply ignore your product because the pain isn't acute enough for them personally.
However, if the workaround is the surgeon is risking their medical registration by sharing patient data over informal channels because the official system is completely unworkable, there is a glaring, urgent opening for innovation.
Because whatever solution you build must be significantly faster, safer, and easier than texting a colleague. Otherwise, human nature dictates they will default back to the path of least resistance.
Which brings us to question 4, the most complex dynamic in healthcare innovation. Who actually pays to replace that tape? This is the buyer versus beneficiary divide.
And as clinicians, we are trained to intervene because a problem causes harm or distress. We act because the patient is suffering. We do not instinctively pause to evaluate whether someone will pay us to apply the fix.
If we connect this to the bigger picture, it feels almost mercenary to think that way.
It's like designing a state-of-the-art parachute for a skydiver. But the person who has to approve the purchase is the pilot of the plane. The pilot doesn't care how soft the landing is for the skydiver. They only care if the parachute takes up too much room in the cabin or if it costs more than the standard issue.
That is a phenomenal analogy and perfectly encapsulates the healthcare economy. It is a highly fragmented ecosystem where the person who experiences the problem, the skydiver, the person who benefits from the solution, and the person who ultimately signs the procurement check are rarely the same entity.
So in our orthopedic example, the patient is experiencing delayed care. The surgeon is experiencing immense frustration and wasted time. The surgeon is the beneficiary.
If you build a seamless software integration that instantly retrieves historical notes, the surgeon's life improves drastically. But the surgeon is not going to pull out a corporate credit card and pay a £10,000 annual subscription fee for this software.
No, absolutely not. The buyer is the hospital trust. Specifically, it might be the chief clinical information officer or the director of finance.
And here is the brutal truth that innovators must swallow. The director of finance does not fundamentally care about the surgeon's emotional frustration.
They care about their own metrics.
Yes. They care about reducing litigation risk from poor documentation. They care about increasing the throughput of the outpatient clinic to meet national waitlist targets. They care about reducing the overtime paid to administrative staff who are currently chasing paper records.
Therefore, if your problem statement only articulates how much time you saved the surgeon, it is incomplete. It's actually fatal to the project.
You must bridge the gap between clinical utility and economic value. Failing to name the buyer early means you will build a beautiful product that clinicians absolutely love, but which absolutely no one can purchase.
So we know the demographic, the severity, the workaround, and the buyer. Question 5. What does a world without this problem actually look like? This brings us to defining concrete success.
It sounds like a simple corporate vision-setting exercise, but it is actually a stringent diagnostic test of your own understanding. If you cannot describe what success looks like in concrete, measurable terms, it means you do not truly understand the parameters of the problem you are trying to solve.
If you say success looks like an easier clinic, that is a failure of imagination. That is a vague sentiment, not a target.
But if you say success looks like the preoperative assessment system automatically pinging the historical implant data into the current electronic health record 72 hours before the clinic appointment, eliminating all manual data chasing by the secretarial team, and allowing the consultant to safely see 2 additional complex revision cases per session without increasing their total clinic time.
Now, that is concrete. That is highly testable. That is an outcome you can engineer backwards from.
Exactly. Wrestling with these concepts, demographics, severity, workarounds, buyers, and concrete success, might take you weeks of deep, focused thought to answer comprehensively. But doing that heavy intellectual lifting at this early stage will save you years of misguided product development.
Right. So you have spent the time. You have your notebook, you have applied the discipline, and you have crafted a problem statement that has survived the crucible. It is a robust hypothesis.
But it is still just a hypothesis living inside your head.
Exactly. The next crucial step is taking that hypothesis out of the sterile environment of your own mind and exposing it to the real world. We call this the validation tour.
Because a problem statement formulated in isolation is highly vulnerable to your own cognitive biases. The validation tour is the antidote. The mandate here is to engage in 20 conversations.
20, not 2.
20 diverse people who theoretically experience the problem you have defined. And crucially, these cannot be your friends, your immediate colleagues, or your mentors.
Wait, why are friends so dangerous in this phase? They know the clinical reality. Shouldn't they be helpful?
They suffer from social desirability bias. They inherently want to support your endeavors. They respect you as a clinician. If you present an idea to a friend, they will subconsciously look for reasons to validate it, rather than rigorously interrogating the flaws.
They don't want to hurt your feelings.
Right. They will give you false positive feedback, which is the most dangerous data an innovator can receive. You need to speak to peers in different environments who have no emotional investment in your success.
But how exactly do we conduct these conversations? If I sit down with a clinical director at a neighboring trust, my instinct is to pitch. My instinct is to say, I have this brilliant idea for an automated data retrieval system. Wouldn't you love to buy it?
If you do that, you have ruined the data entirely. You are leading the witness. You are forcing them to evaluate your specific solution rather than allowing them to reveal the true nature of their problem.
So what's the posture?
You must act as an anthropologist investigating a foreign culture. You must ask open, exploratory questions.
Give me an example of a bad question versus a good question.
A bad question is, do you find it frustrating when you can't find old notes, and would software help? A good question is, walk me through your exact process when you realize a patient's historical records are missing. What happens next?
You're mapping their reality, not testing your product.
Exactly. Or, what is the most chaotic part of your multidisciplinary team meeting? What administrative task takes the most time and yields the lowest clinical value?
And as you ask these open questions, you are listening intently for surprises. Because the clinical insight you walked in with is almost never the exact reality you walk out with after 20 rigorous conversations.
The surprises are where the true value lies. Perhaps you went into the conversation convinced the bottleneck was the legacy software being too slow to load. But through the open questions, you discover that the software is fine. The actual constraint is that the junior doctors do not have the proper login credentials issued to them during induction.
Ah, so they have to physically track down a senior nurse to authenticate the search.
Exactly. The software isn't the primary issue. The hospital's identity management protocol is the issue. Or perhaps you thought the buyer would be the IT department, but you discover that the clinical risk management department has a dedicated budget specifically for reducing documentation errors.
The unexpected constraint, or the surprise buyer, is the most valuable intelligence you can extract. It is also vital to include a control group in this validation tour, isn't it?
Yes, absolutely.
You need to seek out and speak to a few people who theoretically operate in the exact same clinical space, but who do not seem to have this problem at all. Why on earth would we spend precious time talking to people who don't even have the problem we are trying to solve?
Because their lack of the problem is highly instructive. If you speak to an orthopedic unit in a different region and they say, no, we don't really struggle with missing historical records, you must dissect exactly why.
What is fundamentally different about their environment?
Perhaps they employ a dedicated Band 6 clinical coordinator whose sole job is to proactively curate the records for complex clinics 3 weeks in advance.
Which reveals something profound. It reveals that the issue can be solved entirely through non-product means. It can be solved through a simple operational change, a reallocation of human resources.
And if a hospital trust can solve the problem merely by altering a job description and hiring one coordinator, your complex, expensive software product suddenly looks very fragile in the market.
That is invaluable intelligence to gather before you spend your own capital on software development.
This raises an important question which leads us directly to the final group of people you must speak to during this validation phase, and arguably the most important, the failed attempts.
The graveyard.
Yes. You must proactively search the landscape for individuals or companies who have identified this exact problem in the past, attempted to solve it, and failed. You must seek out the graveyard of previous solutions.
I think there's a profound psychological dread associated with this. When a clinician comes up with an idea, they want to believe it is completely novel. Discovering that someone else has already tried to solve your problem staring at the graveyard can feel incredibly deflating.
It feels like someone has stolen your thunder or proven your idea is impossible.
Exactly.
It's completely natural to feel that ego bruise, but you've got to flip that mindset on its head. Finding the graveyard is not a deterrent, it is the ultimate shortcut.
Because they've already mapped the minefield.
Precisely. Those individuals who tried and failed are sitting on a gold mine of data. They possess the operational scars. They know exactly where the hidden traps are located.
But will they actually tell you? If you approach them and say, I am looking at this space, and I see that you tackled this exact issue 3 years ago.
Yeah.
What did you learn, and what ultimately killed the approach? It feels like exposing a failure.
They will almost always tell you. Professionals love to discuss their hard-fought battles, especially if it helps a colleague avoid the exact same fate.
What kind of traps might they reveal?
They might tell you that their technical solution was flawless, but they couldn't integrate it because the dominant electronic health record vendor refused to open their API without an exorbitant fee.
Or they might tell you that the surgeons absolutely loved the workflow, but the nursing union blocked it because it altered their scope of practice without consultation.
Their stories of failure are the literal cheat codes for your success. They will save you years of your life and potentially thousands of pounds of wasted capital.
So we arrive at the culmination of this rigorous process. The clinician has observed the frustration and fought past the inside illusion. They have maintained the 3X discipline, framing the problem rather than rushing to a product.
They've distilled it through the 5 questions.
Yes, and they've conducted the validation tour, spoken to 20 peers, analyzed the control group, and interviewed the failures. They now stand at a critical crossroads.
And it is vital to remember the overarching philosophy here. The goal of this entire exercise was never to blindly validate the decision to build.
The goal was to determine if building is the right next step at all.
Exactly. You have gathered the evidence, and the data will essentially illuminate one of 3 lights: green, amber, or red. Let us explore these 3 places. Place 1, the green light.
The green light means the validation is overwhelming. The problem is demonstrably real across multiple environments. The tangible cost is significant and quantifiable. The buyer is clearly identifiable and motivated.
The current workarounds are inadequate, and there is a clear, definable gap in the market.
So the light is green. We have our map. What is the immediate next step? Do we hire a development team? Do we incorporate a company and seek investment?
Absolutely not.
Really? Even on a green light?
Even on a green light, it is not permission to build the entire final product. It is merely permission to build the absolute minimum prototype or pilot. We call this the minimum viable product, or MVP.
So just enough to test it.
It should be just enough structure to test whether your proposed solution actually alleviates the friction in the real world. Going back to our orthopedic records example, the MVP might not be writing a single line of complex software code.
What would it be then?
The MVP might be running a 2-week pilot using a highly secure IG-compliant messaging thread specifically dedicated to record retrieval, managed manually by a coordinator behind the scenes just to see if the timeline improves and if the surgeons actually engage with the new protocol.
You are testing the fundamental behavior change before you spend money automating it.
Precisely. Prove the clinical utility before you scale the technology.
That is incredibly smart. But what if the data points us to place 2? The amber light. This feels like the most common and perhaps the most frustrating reality for healthcare innovators.
The amber light is incredibly common. It indicates that the problem is undoubtedly real, the pain is there, the clinicians are desperate for a solution, but the environment is currently hostile to your proposed intervention.
If an environment is hostile, my instinct says it's just about money. The trust won't pay for it.
Money is the easy hurdle. True hostility is much deeper. It is often cultural or regulatory. Let us look at a deep case study. Imagine a clinician who has built an incredible machine learning algorithm that uses computer vision to measure acetabular cut placement intraoperatively using the live C-arm feed.
Okay, the problem is real malposition leads to dislocation and revision. The frequency and severity are high. The light should be green.
But integrating this tool requires the hospital's IT department to open their heavily guarded, firewalled network to a third-party application. It requires Class I medical device certification under the new medical device regulations, which costs hundreds of thousands of pounds in clinical evaluation reports.
And crucially, it changes the workflow of the radiographers in theater who might resist the added step.
That is a hostile environment.
So what does a clinician do? Give up?
No, in the face of an amber light, the strategy is strategic patience and positioning. You do not abandon the idea, but you do not recklessly charge forward into a regulatory brick wall either. You build a beachhead.
A beachhead. Give me an example of that.
Instead of trying to integrate the algorithm live in theater, which triggers massive regulatory and IT friction, perhaps you pivot. You first deploy the algorithm purely as a post-operative audit tool, analyzing historical radiographs to identify trends in cut placement.
Because that is a Class I, lower-risk device. It requires zero live integration.
Exactly. You use this beachhead to gather robust clinical data, prove the value, build a business case, and gain champions within the department. You wait for the regulatory landscape to clarify, or you strategically seek out a co-founder who possesses the exact regulatory expertise you lack. Strategic patience is a highly undervalued skill.
It is about finding the path of least resistance to prove the concept. But the most difficult outcome, and the one that demands the most profound intellectual honesty, is place 3, the red light.
The red light. The art of walking away.
The data from the validation tour comes back, and the reality is stark. The problem isn't actually what you thought it was. It might be entirely localized to your specific department's dysfunction.
It might be a real problem, but the tangible cost is so remarkably small that no buyer will ever fund a solution.
Or, most painfully, you discover that a major, well-resourced, monolithic electronic health record company is already rolling out a comprehensive module next quarter that solves the issue perfectly.
When the light is red, the only logical defensible move is to stop. You must walk away.
But we need to acknowledge the ego-bruising reality of this. You have spent weeks, perhaps months, thinking about this idea. You have visualized the impact on your patients. You may have even sketched out designs or spoken excitedly to colleagues about it.
Admitting that it is not viable feels like a deep personal failure.
Because we are trained to persevere, surgical training is essentially an exercise in extreme, relentless perseverance against the odds. To willingly abandon a project, feels anathema to our professional DNA. There is a massive sunk cost fallacy at play.
The sunk cost fallacy is the absolute death knell of the clinician innovator. It is the irrational belief that because you have invested time and emotional energy, you must continue, regardless of the glaring evidence. But the clinicians who have the emotional intelligence and the intellectual rigor to walk away from a doomed idea gracefully are the true experts in this field. Walking away is not a failure. It is a highly successful experiment that yielded a negative result.
By walking away, you save yourself years of wasted life, you protect your capital, and crucially, you preserve your creative energy and your reputation for the next insight, the one that actually warrants a green light.
It is about conserving your ammunition for a target that is actually viable.
As we wrap up this deep dive, let us summarize the journey we had mapped today. We started with the clinician's notebook, the raw, unfiltered list of systemic fractures that occur at the coalface of medicine.
We learned to interrogate those frustrations, fighting the inside illusion and demanding independent verification, persistence, and tangible cost to separate a bad day from a systemic problem.
We discussed the critical discipline of separating the problem from the product, ensuring we do not lock into a premature solution and instead spending 3 times as long dwelling in the problem space.
We deployed the 5-question framework to refine the observation into a testable hypothesis, specifically defining the demographic, the frequency and severity, the bar of the workaround, the economic buyer versus the beneficiary, and the concrete metrics of success.
And finally, we outlined the validation tour, the 20 open conversations, the control group, and the invaluable lessons from the graveyard of failed attempts, leading us to the crossroads where we must objectively decide to build a prototype, exercise strategic patience, or gracefully walk away.
It is a rigorous map, but an essential one.
Before we conclude, I want to leave you with a final provocative thought. It is something we haven't explicitly named yet, but it underpins everything we have discussed. Look closely at your own mental list right now.
Think about that one idea you have been nurturing in the back of your mind for years.
Are you protecting it? Are you intentionally keeping that fragile idea hidden from the harsh light of validation because, subconsciously, you are afraid it might not survive the scrutiny? The fear of finding out your idea isn't viable often paralyzes clinicians, trapping them in a state of perpetual safe theorizing.
It is a profound question. Doing the hard, unglamorous work up front, the rigorous interrogation, the uncomfortable conversations, the willingness to be proven wrong, is the sole difference between building something that actually works in the complex reality of healthcare and building something you merely wish would work.
The system does not need more well-intentioned wishes. It desperately needs robust, battle-tested solutions.
Absolutely.
Exactly. If this deep dive helped clarify your own clinical insights, or perhaps challenged your assumptions about an idea you are currently working on, please take a moment to rate and share the show with a colleague who has a notebook full of ideas of their own. Innovation in healthcare is a team sport, and sharing the map is the first step.
Well said.
So what does this all mean? It means your initial insight, that flash of frustration in the clinic or the theater, is not the destination. It is merely the beginning of the diagnostic process. The real work is treating the problem with the exact same rigorous, analytical, and unsentimental scrutiny that you would apply to a complex fracture on a radiograph. Talk soon.